Well, hi everyone, it's Jake here with IBPF once again, and I want to thank you all for joining us on today's webinar on the topic of the interface between bipolar disorder and substance use disorders. Today's webinar features Dr. Stephanie Nichols. Stephanie Nichols, PharmD and MPH, is an associate professor in the University of New England, located in Maine, adjunct clinical assistant professor in the Tufts School of Medicine, core faculty in the Maine Medical Center Addiction Medicine Fellowship Program, an instructor in the Psychiatry Residency Program. As a psychiatric pharmacist, she is passionate about advocating for people with unmet psychiatric and substance use disorder needs. And outside of work, she enjoys spending time in the woods with her partner Eric and pups, Sage, Basil, and Penny. She also enjoys yoga, reading, gardening, painting, and lighthouses. I want to let everyone know there will be a 15-minute question and answer session at the end of this webinar. So feel free to think about your questions throughout. You can even drop them in the chat box and we'll get to those at the end. And with all that being said, I'm honored to introduce our featured speaker, Dr. Stephanie Nichols.
Thank you so much for that lovely introduction and for inviting me to be here today. I'm really excited to share information, excuse me, about bipolar disorder and substance use disorders and the interface between the two types of disorders. So by the end of this talk today, I hope we're all able to describe the epidemiology of substance use disorders in patients with bipolar disorder, identify potential common etiologies between bipolar disorder and substance use disorders, and we'll look a little bit at some of the common genetic factors, as well as talk about socioeconomic and environmental factors. And then finally describe how substance use disorders impact the treatment of bipolar disorder, and then vice versa, how bipolar disorder impacts the treatment of substance use disorders. And we'll talk about specific medications during that section as it applies. So I have no conflicts of interest to disclose today. So let's start with a little bit of the epidemiology here. So talking about bipolar disorder and substance use disorders and comorbidities. So about a quarter to 2/5 or so, 26 to 43% of people with bipolar disorder have diagnoses of substance use disorders. And this number varies from study to study. One of our most robust studies in bipolar disorder, the STEP-BD study, which is on the older side now, but again, one of our most robust studies we have in this disorder, found that more than half, up to 51% of people in that study who had bipolar disorder also had a substance use disorder. So bipolar disorder and substance use disorders are extremely, extremely common. Further, we know that people with bipolar disorder are 5 times more likely to use an illicit substance. So the odds ratio is 4.96, so 5 times more likely to use an illicit substance. And we'll get into the rationale, the reasons a little bit later. We'll hear some thoughts from 15 people with bipolar disorder who use substances and some of the reasons why substance use occurs. But finally, on this slide, some studies have shown higher rates of substance use disorders in men who have bipolar disorder versus women who have bipolar disorder. So some studies have found there might be a gender difference. And again, we'll talk about gender differences here today a little bit later in the slide set. Other studies haven't found a difference between men and women. So there's some uncertainty there. There might be a gender difference. We'll talk about that a little bit more. So let's talk about the specific substances. So this here is looking at prevalence of substances, mostly looking at prevalence of substance use disorders, but in some situations, such as this first cannabis statistic and this tobacco statistic, this is looking at substance use. With tobacco, the vast majority of people who use tobacco have tobacco use disorder because tobacco is extremely reinforcing, particularly the way it has been marketed to us as humans via cigarettes. However, other substances don't have quite the same degree of overlap between substance use and substance use disorder. So cannabis here, you can see over 2/3 of people with bipolar disorder use cannabis. So 70% report using cannabis. However, only about 20 to 30% of people with bipolar disorder have a cannabis use disorder. So I think this really illustrates that with substances, you can have use in people with bipolar disorder and not have a substance use disorder. However, you can still see here that about 1/3 or so of people who have bipolar disorder who use cannabis have a cannabis use disorder. So cannabis is one of the most common substances used by people with bipolar disorder. Alcohol is another very, very common substance used by people with bipolar disorder. And with alcohol, we can see the rate of alcohol use disorder now here in bipolar disorder. It's a wide range. Again, it depends on the study methodology, but about 1/3 up to 2/3 of people with bipolar disorder have not just use alcohol, but have alcohol use disorder. That is striking. And it's a really important opportunity to treat people, to screen and treat people for alcohol use disorder who we already know have bipolar disorder, right? It's a huge opportunity. So alcohol use disorder is extremely common. Cannabis use is common in bipolar disorder, but cannabis use disorder is a little bit less common. And then tobacco use and tobacco use disorder is also extremely common in people with bipolar disorder. You can see that use of stimulants is not unheard of in people with bipolar disorder, and about 1 in 10 to 1 in 4 people with bipolar disorder do have cocaine use disorder. Opioid use disorder in people with bipolar disorder is fairly uncommon. So one study found only 6% of people with opioid use disorder, with bipolar disorder have opioid use disorder. So among the substances, opioids do seem to be much less commonly used in people with bipolar disorder. That said, we know opioids are used extremely frequently. And so I want to talk about this, and I'll link this to deaths of despair in just a second here, but I think this is a really important point. One study, this was shocking to me, this is striking, and it wasn't that old. I think this was the 2017 study, found that over half of all prescriptions for opioids in this country were prescribed for individuals with a mental health diagnosis. And that population in this study, so the same study, same population, was only 16% of the population. And this was a representative of US population study. So about 16% of people have a mental health diagnosis in this study methodology, and over half of those people were receiving opioid prescriptions. And so I think that's really, 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 really striking to think about when we think about this sort of whole interface between un and undertreated psychiatric illness, including bipolar disorder and substance use, and again, sort of unmet needs that are occurring. So I think one thing that might be going on here is that there is evidence that shows us that emotional pain as well as physical pain is activated in the same area of the brain, and opioids relieve both of these. So looking at PET scans, it's been shown that opioids relieve not just physical pain, but emotional pain. And so maybe for a really long time, maybe for 20 years or so, in a lot of people, suffering has sort of come out as pain and resulted in opioid prescriptions, but maybe that's not the actual suffering that's happening, right? Because while opioids relieve emotional pain, they are absolutely not the best way to treat emotional pain, because that's an acute relief. And we know that development of opioid use disorder over time certainly A, increases pain with hyperalgesia, but also B, can worsen underlying affective conditions like bipolar disorder. So we'll come back to that point in just a minute about opioids when we dive a little bit more into deaths of despair. So I want to spend a little bit more time talking about most common substances that are used, and then also most common substance use disorders in people with bipolar disorder. So looking over here on the left-hand side, this is looking at lifetime prevalence, and you can see different continents. So, well, continents and countries. So we've got Asia here, non-USA and non-Asia, and then USA and Black. So really sort of looking in here again at us and in the United States. So lifetime prevalence in this study of alcohol use disorder, again, about 40%. Remember the other study, it was about 30 to 70% or so, 35 to 70%. Cannabis here, this is a cannabis use disorder. So again, lower than cannabis use overall, but still certainly something that is one of the more common substances being used. Cocaine and other stimulants, and we'll look a little bit more in a second at other stimulants on the other side here. Again, not the most common substance, but 15% or so in this study. This is combining all drug use, so drug use disorder sort of combining all together to get the prevalence here, and it's about the same as alcohol use disorder, and then combining alcohol use disorder and other substance use disorders for all substance use disorders here gives us over half. So again, people with bipolar disorder are more likely than not to have a substance use disorder, and you can see that if we put this alcohol use disorder bar on top of the drug use disorder bar, it would be much higher than this number, because this number reflects people with polysubstance use disorders, oftentimes including alcohol use disorder, maybe cannabis use disorder, and maybe cocaine use disorder or another use disorder. On the right-hand side, you can see this is looking at the prevalence and looking at the difference in prevalence in the community versus in the clinical setting. So community is on the left-hand side in the white bar, and the right-hand side is the clinical setting in the black bar. And you can see almost across the board there, the prevalence of substance use and substance use disorder is more common in the clinical setting, with the exception of hallucinogens, which I think makes a lot of sense when you think about access and other factors. And then interestingly, overall drug use disorder, although statistically neither of those were different from each other. So again, you can see the same thing. Substance use disorders overall more common in the clinical setting, but still extremely common in the community. Alcohol use disorder is one of the most common ones. In this study, they broke out amphetamine and cocaine, but in my mind, those are both stimulants. And so really thinking about them together makes a little bit more sense, particularly when we're comparing other classes like opioids and hallucinogens. So when we pile amphetamine and cocaine together as stimulants, you can see now the prevalence rate is about 1 in 5, and it's very similar to a cannabis use disorder. Okay. So, but it gets a little bit more complicated here, particularly with bipolar disorder, because bipolar disorder inherently by definition has different episodes, different phases, right? One of the things I'm actually trying out, a new word I'm trying out, so I'm interested to hear your thoughts about this, is thinking about some of our, what we call episodes as flares. So bipolar disorder with like manic flares or depressive flares. So I'm curious to hear your thoughts about that specific term relating to other diseases like arthritis, for example. But either way, I digress. Bipolar disorder has these episodes, these flares, these different sort of periods of presentation, right? And depending on the type of presentation is going to depend on the type of substance that someone might reach for if someone is looking to self-treat the symptoms that are at hand. And so a substance that might be reached for in the setting of a manic episode or a manic flare or hypomanic flare episode, or might be very different than one reached for in a depressive episode or flare. So before we get there, though, also, of course, there are different types of bipolar disorder. We have bipolar disorder 1, bipolar disorder 2. Bipolar 2 patients and people do not ever have manic episodes. So they have hypomanic episodes or flares, but never full-blown manic episodes. So that's one major difference. And the time frame is usually shorter. So I want to, this also includes unipolar depression, which would be major depressive disorder, and then sort of lumps all affective disorders here. But what I really want us to look at is bipolar 1 and bipolar 2. And then look over here at any substance use disorder, alcohol. This is some of the old terminology in DSM-4, where alcohol dependence and a term we no longer use anymore, alcohol abuse. I kept this here because it is specific diagnostic terminology from DSM-5 that was used. Now with diagnostic terminology from DSM-4 that was used. Now with DSM-5, dependence and what we used to abuse, which is a term that we no longer use anymore, are combined together as a use disorder. So alcohol dependence and this third category would be alcohol use disorder combined. But in this study, it happened, before it was 2002. And so we were using DSM-4, and this is the terminology and the way that it was framed at that time. And so that's why it looks like that. So a couple of things I think that are important to pull out from here. Number one, interestingly, if you look at dependence of alcohol, about 1 in 3 people with bipolar 1 met criteria for alcohol dependence, which was a higher rate than the rate with bipolar 2, about 1 in 5. But when you look at what we used to call alcohol abuse, which is, maybe a more severe alcohol use disorder, you can see that there's actually a higher rate in people with bipolar 2 versus bipolar 1. That said, people with bipolar 2 still were more likely to meet criteria for dependence, but a higher rate of abuse compared to bipolar 1. When we add them together to make alcohol use disorder, you can clearly see, so it's about 40, 45, 46 or so, right? And about 40, right? So a little bit higher still in bipolar 1, but it's interesting, a different presentation between distribution between bipolar 1 and bipolar 2. So let's see if there's anything. Yeah, so I think we hit all those. Oh, and so the specific criteria down here on the bottom that were under dependence versus under abuse, you can see. So abuse specifically included things like drinking in dangerous situations, like maybe drinking while driving, recurring legal or relationship problems, and failure to fulfill responsibilities. So often considered a little bit more severe because it's impacting more of life functioning. However, what we used to call alcohol dependence is also significantly impacts life functioning, which is why DSM-5 has combined them together and doesn't differentiate if a patient has, 2 to 3 symptoms of this section versus this section. So if someone has like cravings, increased tolerance, and failure to fulfill responsibilities, that person has alcohol use disorder, right? So I think that's one of the advantages of DSM-5, and I will move on there. Okay, so I'm coming back to what I briefly touched on before, which is deaths of despair. And thinking about our use of opioids and thinking about how not a lot of people with bipolar disorder, there's a low prevalence of opioid use disorder in people with bipolar disorder, but there's a high prevalence of use of opioids in people who have mental health challenges. Okay, so building on that, we know that there's a significant overlap between death by unintentional overdose and death by suicide. And so putting these two together, we can call these two types of deaths of despair, right? So when somebody dies by suicide or when somebody dies by unintentional overdose, those are both end of these manifestations of just despair, right? Just florid despair. And so those two types of death have a lot in common, and we can learn a lot by looking at them combined under this common umbrella, and also find a lot of opportunities to help people who have a lot of unmet needs. So one author estimated that about 30% of unintentional overdose deaths are likely death by suicide. Death by suicide is challenging to identify unless there's sort of a clear like paper trail. So there's a lot of uncertainty around this. And so that led this author to conclude that about up to 30% of unintentional overdose deaths were likely death by suicide. So that author made that assertion in 2017. So building sort of that and looking at that 30% adjustment in that same year, about a quarter of all death by suicides in 2017 in our country were by opioids. So really, 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 really important factor in deaths of despair and including death by suicide. And so this is just some evidence to show you here. What I really want to hone in here is this fourth column over suicide and unintentional overdose combined. The numbers here go from 2000 2006 in sort of like the mustard color, 2011 in green, and 2017 in blue. And so this is the rates of suicide and unintentional overdose combined. And then you can see in the far column here, these are the ones that involve opioids. And if you do the math and calculate out the percentage, what you can see is a really, really, really clear story, which is from 2000 to 2017, deaths of despair that involve opioids continue to rise from 17% to 26% to 29% to 42% in 2017. And I would guess the number might be over 50% now with newer numbers. We don't have newer numbers. I'm hoping and waiting for them just because I think it would really be important for us to be able to continue to advocate for increased access to care and funding for services. So, I think it's important to think about the role of opioids in death by suicide as well as overdose death, and think about sort of deaths of despair as a larger umbrella. Now I want to turn and think about gender differences. So I touched on those very briefly right at the beginning. So gender differences in bipolar disorder. I'm just going to look at time. Okay. And substance use disorder comorbidities. So in one study looking at about 267 people with bipolar disorder, about a third, a little over a third, had alcohol use disorder. What they found is men who had bipolar disorder had a greater lifetime prevalence of alcohol use disorder than women who had bipolar disorder. So men had a 49% lifetime alcohol use disorder prevalence versus 29%. And then compared to the general population, excuse me. So in people with bipolar disorder, greater lifetime prevalence in men versus women. However, compared to the population, women with bipolar disorder had a higher risk of alcohol use disorder versus women without bipolar disorder, compared with men with bipolar disorder versus men without bipolar disorder. So this first bullet is talking about everyone with bipolar disorder, women with bipolar disorder versus men with bipolar disorder. The second bullet is talking about women with bipolar disorder are 7.35 times more likely to have alcohol use disorder than women without bipolar disorder. And for men, it's about threefold, right? 2.77 times more likely to have alcohol use disorder versus men without bipolar disorder. So while men overall with bipolar disorder are more likely to have alcohol use disorder, we know that men without bipolar disorder are more likely to have alcohol use disorder. So when we actually look at women with bipolar disorder versus women without bipolar disorder, you can see there's a much larger discrepancy, which means that a lot of our focus on screening and treating alcohol use disorder in men is definitely well-founded when you look at population, but we cannot forget about women and people who are non-binary, and we especially cannot forget about women with bipolar disorder based on this data right here. Also, it was shown that people with women with bipolar disorder were more likely to have alcohol use disorder if they also had social phobia and depressive episodes. And so, a quote, I couldn't say it any better, so I decided to just keep it as a quote from the paper is, women with bipolar disorder appear to be particularly vulnerable to alcoholism. I do want to point out this quote was from 2003, and at the time that was the terminology that we used, but we now use the phrase alcohol use disorder. But I think the point still stands. Women with bipolar disorder appear to be particularly vulnerable to alcohol use disorder. And again, this was from 2003. I don't think a lot of people are talking about this or thinking about this. Huge missed opportunity, especially because we know how much alcohol leads to fatalities, right? And rising alcohol-related alcohol and alcohol complication-related deaths in this country. Okay, so we've talked a lot about epidemiology. Let's talk a little bit about what people with bipolar disorder say about using substances. So sort of some of the rationale. So this study spoke with 15 people with bipolar disorder. It was in small focus groups, and they focused on 5 different points here. They focused on experimenting in the early course of illness, living with a serious mental illness, enjoying the effects of substance use, feeling normal again, and managing stress. So these were the themes that came out of these focus groups. These were the themes that the participants were telling the researchers. So let's dive into those a little bit more. I think it's always important to hear what people with lived experience have to say. We can't do that enough. So starting with the first reason, experimenting in the early course of illness. So this first person was reflecting on dangers of drinking during mania. And they said, what I used to do when I was manic, I'd go out and virtually drink myself to death, to the point of collapse. If you're high, you know something's wrong. You know that, but you don't seem to be able to control it. I was drinking and not eating to the point where I'd virtually shut down. So, sort of talking about substance use and maybe risky substance use during manic episodes and knowing something's wrong, but not being able to control it. The next person talked about alcohol effects on depression. To be honest, I tried to ignore them, the symptoms of depression, in hope they would go away. I was drinking at that point, just kind of relaxed me, and alcohol blotted things out. So describing using a substance, in this case, alcohol, to blot out the symptoms of depression and sort of provide relaxation. And then the bottom quote talks about the use of cannabis and effects on mania. I was doing cannabis not to get high. I was doing it to bring me down a bit. I always had a vision of cannabis as something you chill out with. And so this person was describing trying to, it appears, trying to self-treat their manic symptoms, right? Bring themselves down a bit. So now moving into reason 2, living with a serious mental illness. So on substance-induced mania, with excess alcohol, then sometimes I can bring on a bit of a high on. Whether it knocks the medication out of your system or what, I don't know. But it's a bit dangerous. With an all-night drinking session, that has happened in the past. And so, really talking about alcohol bringing on a manic episode or a manic flare in this person. On the flip side, alleviating manic symptoms. Only drinking a few times now, but it can work sometimes. It sort of puts a lid on the high. People have said, don't take these things, but then you can be too clear-headed. Seems to start with or be related to mania sometimes. I think it helps to bring yourself down a bit. So again, sort of describing using, again, in this case, alcohol to tamp down or treat some of the symptoms of mania. And then the bottom here, someone talked about treating anxiety and depression. Well, I drink 2 or 3 times a week now. I drink to quell my anxiety when I'm in a depressive mood and get anxiety. And so again, sort of talking about self-treating the anxiety that comes with their depression with alcohol. Another reason that came up was enjoying the effects of substance use. So interestingly, so far, we haven't talked about what, for a really long time was put forth as the reason why people use substances. We haven't really talked about, just trying to be euphoric to get euphoria. Maybe a little bit here early on, but a lot of these themes are around self-treating, right? Self-treating on and undertreated symptoms. So this is going to talk a little bit about enjoying the effects of substance use, but again, not as much as we might be led to believe. I'm a DARE graduate, and I was led to believe that was the only reason ever for substance use, and that's clearly not the case. So what is the case? So for euphoria, somebody said, I think it's just a really feel-good factor, cocaine. It just felt dead good, like all is well. And then someone else said on self-enhancement, I was on me medication, but I was smoking cannabis and enjoying it. That's not a typo. This was a study that I think was done in Ireland or Scotland, but that's not a typo. It did in fact say me medication. But either way, the point of the quote is the person was on their medication, so they were taking their medication, which is great and really important, and then also smoking cannabis and enjoying it. So then I think more discussion about, what I would say again is treating un and undertreated disorders, be it bipolar disorder or substance use disorder. So, kind of feeling normal again. So talking about medication adherence and alcohol. So I still drink 2 nights per week and miss my medication. I've told the psychiatrist that, and they have told me as long as you don't drink too much and take your medication, but I've told them I don't. 2 nights off a week for me. Well, it's psychological. I feel a bit normal. So this person is saying, I take medications all the time, every day, and I just want a break and I want to feel like a person who maybe doesn't have bipolar disorder just for a period of time. And so I think this is an opportunity here for the provider to talk with this patient and come at it from a harm reduction perspective and think about, is it safe for them to drink while they're on their medications? Because maybe it's better for them to take medications 7 days a week rather than 5 days a week while they're going to drink the 2 days per week. So really listening to people and their reasons for using and what they're hoping to achieve and what they think they're getting out of the substances is so, so, so important. So the next person said alcohol and decreased stress. Well, alcohol just makes you feel good. It just like dulls all your senses and puts things on the back burner just for a few hours. Like, you try to feel normal. Well, that's what I think anyway. So again, just trying to feel like someone who maybe doesn't have bipolar disorder, just trying to get a break from this serious and persistent mental health condition. On the bottom here, on social use of cocaine versus solo use. Very occasionally, like if I was sat next to some bloke in the pub and he offered me speed, I'd find it really hard to say no. I don't go out and buy it. It's generally in that situation. It is by its nature like Coke, a drug you don't want to be taking on your own. So talking about, generally not using stimulants or Coke specifically on their own, not going to buy it on their own, but if someone offered it to them in the pub, they would be happy to use it. So more of sort of social and feeling normal, feeling like having normal human interactions that a person might perceive they otherwise wouldn't have. And the final one is managing stress. So starting at the top with drinking after loss. So in bereavement, not after my daughter died, but after my brother, for about a year after losing him, I did drink a hell of a lot. So using alcohol for bereavement and probably depressive symptoms we can guess in that situation. So again, self-treating. Drinking for sleep, because I was experiencing all this when I was in a stressful job. I remember I couldn't sleep. The only way I could cope with it was, well, one of the things was drinking. So, managing insomnia with alcohol, which we know can help with falling asleep, but definitely can cause more insomnia on the back end. But this is something if a patient talked to their provider about this is why they were using alcohol, the provider might be able to help in other ways that are not as problematic health-wise, because we certainly know that alcohol over time can lead to alcohol use disorder. And we know alcohol use disorder can cause all sorts of complications in life, not only liver disease, but a whole bunch of different types of cancer, cardiovascular disease, other psychiatric and neurologic conditions, etc. The last quote here is drinking to self-treat depression. I was not diagnosed, but clinically depressed for 3 years, between the ages of 14 and 17. I was drinking excessively to blot out emotional pain. So I think this is so common. And, I would love if we did a better job as a society, screening our adolescents who are drinking for bipolar disorder, because I think, maybe that not just screening one time, but screening and watching to see, certainly into early adulthood, because I do think that may be an important indicator that a person might have bipolar disorder, and we might not have picked it up yet because they might not have had a manic or hypomanic episode. Definitely something to think about. You know, I certainly major depressive disorder can have, people can have episodes as adolescents as well, but it tends to be less common. And if someone's having earlier episodes, they're more likely to have bipolar disorder in general. And so, you know, we know that a lot of people use alcohol to self-treat depression. And so if we have adolescents using alcohol, particularly alone, I think it's a really important screening opportunity. Okay, so that was all about substance use. Now I think we should talk about why people with bipolar disorder develop substance use disorders, because we looked at the numbers, that the prevalence is much, much, much higher than the general population. So what is going on here? Well, that's a good question. There's a lot of things it could be. We don't know that the absolute answer by any means, but I will share with you some of the things we do know. So there's a lot in general of CNS overlap, right? So we know bipolar disorder, you have alteration in the inferior and dorsolateral prefrontal regions of the brain. You get a disruption in the limbic system of the brain, and then you get this aberrant connectivity between the two. So we know that about bipolar disorder. And we know with substance use disorders, you have the pathophysiology of substance use disorders involves parts of the prefrontal cortex, including the orbital and medial prefrontal cortex, and then a whole bunch of dopamine pathways, but specifically the important mesolimbic dopamine pathway from the ventral tegmental area out to the nucleus accumbens. So let's look at some genetic factors. I think this is maybe, for me at least, some of the most compelling information here. You know, just like with most psychiatric conditions, it's all about sort of genetic susceptibility and, you know, probably early life trauma or other events that sort of turn on the condition, right? That's really seems to be the story for most of psychiatry and probably bipolar disorder, excuse me, probably substance use disorders as well. So genetics are really, really important. They're not the whole story, but really, really important. So when we look at people, we have identified a tenfold higher familial association of alcohol use disorder and bipolar depression. So when looking, there's for unipolar depression, for major depressive disorder, there's about a 70% increase if there's familial alcohol use disorder, also having sort of familial unipolar depression. But that risk is 14, you know, almost 15-fold higher with alcohol use disorder and bipolar disorder. So unipolar depression is probably not all the same thing. We're probably calling 3 or 5 different things unipolar depression, but bipolar disorder does seem to be a little bit more concrete. And from a genetic perspective, that's important when we think about shared risk factors like alcohol use disorder. Further, half, 47 to 57% of genetic variants that predisposes someone to having bipolar disorder also has been shown to influence the risk for alcohol use disorder. Half. That's extremely high. And I think that explains a lot of what we see when we look at prevalence of comorbidities between bipolar disorder and substance use disorders, right? This is sort of a lot of it is underlying shared genetic factors. There have been identified 2 shared genetic loci, that are identified between alcohol use disorder and bipolar disorder. It's really small. It's hard to see here, but I don't think you need to see it. You can pull a reference if you want to. The whole point is to see this sort of dot up here and then this other sort of dot up here to show you that the 2 different shared genetic spots. Then there's some other candidate shared genetic polymorphisms that have been identified. So polymorphisms with aldehyde dehydrogenase and alcohol dehydrogenase might also be important for bipolar disorder. Also polymorphisms in a specific serotonin gene, the serotonin 2C receptor gene in women specifically. So that might explain why it's much more common to have comorbidity with women with bipolar disorder. And then finally, this other one, which confers the catechol methyltransferase, which is one of the enzymes that metabolizes dopamine in the body. So looking now at socioeconomic and environmental factors. So we know early stressful life experiences can lead to stress sensitization. So again, sort of the genetic predisposition and then early stressful life experiences. So and that can cause this increased stress or responsivity to stressors in adulthood. So a less ability to tolerate stress and distress. So the sensitization pathophysiology, it's thought to have to do with alterations in BDNF or brain-derived neurotropic factor, and then also hyperactivity of the striatally based habit memories. So the nucleus accumbens, remember the ventral tegmental area to the nucleus accumbens dopamine pathway that's really important for substance use disorders. So here it's thought that same nucleus accumbens is hyper responsive, and that is thought to lead to learning because we now realize that dopamine is an important learning factor as well. So in this case, learning to be hyper responsive to stress. And then finally, an inability to exert disinhibition via the prefrontal cortex as well. So this is what can happen with sensitization pathophysiology, and this can occur with early stressful life experiences or adverse childhood experiences. Also with household on or undertreated mental illness and substance use disorders, so in the parents or caregivers, and then also any kind of household violence that's occurring. So to round this out, we'll just spend a tiny bit of time talking about the impact. So first we'll talk about the impact of substance use disorders on the treatment of bipolar disorder, and then we'll talk about the impact of bipolar disorder on the treatment of substance use disorders. So starting with the impact of substance use disorders on the treatment of bipolar disorder. So we know that substance use disorders, particularly when they're on or undertreated, can lead to just more life chaos for a wide variety of different reasons. But that chaos can result in reduced medication taking. This could be because of forgetting. It could be because of intention to forgo, like the patient talked about 2 days a week wanting to stop medication and drink, right? Lots of different reasons. But ultimately, we know that substance use disorders can lead to reduced taking of medications, and that can impact the therapeutic levels, particularly when we're talking about mood stabilizers like lithium, like valproic acid, for example, even lamotrigine as well, but that one's a little tiny bit more forgiving. Further, substances may be inappropriately substituted for medications, and we saw some of those in some of the quotes. So somebody might not be getting the effects that they are hoping to get from their medication. So they might be on a mood stabilizer, but they might still be experiencing depressive episodes. And if that's the case and they're reaching for substances instead, that's a missed opportunity to identify that this patient needs, maybe another medication added, or maybe a switch in medication, maybe a non-medication treatment. There's a lot of really effective treatments that are non-medication as well, like ECT for bipolar disorder. We know that stimulant use can precipitate a manic episode. Not in everyone. We know there is a comorbidity between bipolar disorder and ADHD. So, there are people with both conditions, and we do know that stimulants are the most effective treatments for ADHD. However, we also know that stimulant use can precipitate a manic episode. I think we saw that in one of the quotes in someone using cocaine in that way. And so that's something that needs to be watched for if someone has bipolar disorder, especially bipolar 1, and uses cocaine or any other stimulant outside of the medical system. Ketamine and psilocybin can treat a depressive episode. Ketamine, S-ketamine, it's an enantiomer, is FDA approved for major depression, as well as bipolar depression and suicidality. Psilocybin is not approved for that, and it's actually still illegal in this country, but it's being studied, and I think it will come to market at some point. But there is good evidence to show that it can treat a depressive episode, and also some substance use disorders. Alcohol use disorder in particular has some really, really good evidence in responding to psilocybin. Alcohol and cannabis can precipitate depressive episodes, so that's something to be aware of. And it's one of those things where sometimes patients will have the effect they're looking for early on in use of those substances, either helping with sleep or depression or even anxiety. But like over time, with more and more use, your brain changes. And so those can actually cause increased depression, increased anxiety, and sometimes, particularly with alcohol, increased insomnia. And then Post-acute withdrawal from alcohol. So I'm not talking about acute alcohol withdrawal, in the 12 to, 3 to 4 days after stopping alcohol. I'm talking about in the first 6 to 12 to like 18 months after stopping alcohol. So post-acute withdrawal from alcohol, it can be extremely challenging. So if someone does have bipolar disorder and they have alcohol use disorder and they are in recovery, especially early recovery, they can be expected to have, and this is for anyone, but particularly people with bipolar disorder, expected to have massive sleep disruption, emergence of trauma that might be being suppressed by use of alcohol, again, particularly people with bipolar disorder, and then profound instability overall. There's a major risk of death by suicide in the first 6 to 12 months after cessation of alcohol. And so it's really important that a patient has appropriate support in place during that period of time. It is still worth it. It is still worth it, but that is a risky period of time. It is still worth it to help the person with alcohol use disorder be in recovery for alcohol use disorder. It's worth it, even though this is a risky time, but this is a risky time and the patient needs to be monitored. And then the flip side here, and then we're gonna finish up and move into questions, is thinking about impact of bipolar disorder on treatment of substance use disorders. So bipolar disorder, again, we talked about the instability, right? It's a cyclic disease. Substance use manifests this, and so it's just something to be thinking about. Substance use often matches that unmet need. So we kind of talked about this, but sometimes if people are experiencing insomnia, they might reach for like sedatives like benzodiazepines or alcohol or cannabis. For pain, and that could be emotional pain, somebody might reach for opioids or alcohol or cannabis again. And then if someone wants to feel hypomanic, maybe they might reach for stimulants, or to feel the opposite of depressive symptoms, they might reach for stimulants. Mood stabilizers can interact with substances. Carbamazepine or Tegretol interacts with like so many different substances. So if you're on that, please reach out to you are using substances, or someone who's on it and using substances, please have them reach out to their pharmacist. We do have databases and we can look these things up, even for non-FDA approved substances. And it is important because there are major interactions. Valproic acid or divalproex or Depakote, when that's combined with excuse me, when that's combined with alcohol, that increases the risk of liver toxicity. And then abruptly stopping any mood stabilizer that is an anti-seizure medication, so valproic acid or divalproex, carbamazepine, lamotrigine or Lamictal, can cause seizures. And that also interacts with many, many substances that somebody might be purchasing and using. Lithium, if someone's taking lithium, there is an important requirement of adequate hydration because lithium is renally eliminated, all renally eliminated, and it can cause acute kidney injury, particularly if a patient isn't having adequate hydration. So if somebody is using substances that make intake more challenging, maybe like stimulants, or make diuresis occur, like excess alcohol ingestion, where someone's just peeing all of their water out, they can be at higher risk for lithium toxicity. Treatment with tobacco use disorder with varenicline or Chantix has been shown in some studies, some situations, to worsen symptoms of bipolar disorder, and patients should be monitored. But it is the most effective treatment we have for tobacco use disorder, and tobacco use disorder is common in people with bipolar disorder. So varenicline should not be withheld in people with bipolar disorder, but rather those patients should be monitored more closely. And then stopping smoking and starting smoking can affect the levels of many mood stabilizing antipsychotics, particularly olanzapine and clozapine if somebody is on that. So some final treatment pearls, long-acting injectables can help provide stability it's just like one layer of stability. We have 3 meds in psychiatry, 3 meds in medicine that actually decrease suicide, right? Lithium, ketamine, and clozapine. So just kind of keeping that in mind. Approaching patients from harm reduction perspective, talking about reality rather than ideal medication taking, right? So a patient wants to drink 2 days a week. They're going to drink 2 days a week. Talk about, okay, it's safe to take your medication all 7 days, even while you're drinking, rather than just, no, you can't drink because that's not the reality in that situation. Providing safe, caring, supportive, and stable relationship over the long term, even when things are extremely unstable, can't be understated. And then finally, I want to give a call out for pregnancy. Particularly pregnancy happens in general. People with bipolar disorder sometimes experience manic flares or manic episodes, and sometimes that involves hypersexuality, which also could contribute to someone maybe becoming pregnant. And so it's important to continue mood stabilizers and MOUD, like buprenorphine, for example, or MAUD, like naltrexone, if someone does become pregnant. Except for valproic acid, which we will always stop if someone becomes pregnant. I am going to leave these call to actions for the slides because I think I hit a lot of the points and I do want to have some time for questions. So I am going to leave it right there.
Excellent. Well, Dr. Nichols, thank you so much. And we're going to dive right into the question and answer session. So if you have any questions, please type them in the question box and we'll try our best to get to as many as we possibly can. And so our first question is, does the presence or absence of therapy correlate with substance use disorder in individuals with bipolar disorder?
Ooh, that is a good question. And I don't have that evidence at my fingertips right now. What I would say anecdotally, what I've seen in my practice is that it correlates with reduced substance use. And part of that is because of the therapeutic relationship over time. Part of that, I think, has to do with, I don't think accountability is the right word, but sort of a routine discussion, I think. But again, that is anecdotal. I don't have the evidence off the top of my head.
Good to know. And so our next question, our audience member says that they are surprised by the low fraction, 6% of opioid substance use disorder and the high rate of suicide by opioids overdoses. How is the link made between the opioid and the suicide rate on top of other substances, which would match the substance use diagnosis?
Yeah. So just to be clear, the data with death by suicide and deaths of despair more broadly, those were not specific to people with bipolar disorder. Those were the US population more broadly. As far as the link, one factor I think that's at play here that may actually have helped a lot of people with bipolar disorder is I think that because of the concern of risk of overdose with opioids, that opioids weren't as liberally prescribed in people with bipolar disorder. And that might vary a lot from, area to area, but at least in my area of the country, during the time when opioids were much more liberally prescribed, serious and persistent mental health conditions were sometimes still a pause to an additional consideration of safety, and that may actually work out to the benefit of the population of people with bipolar disorder now, in that there's a lower rate of opioid use disorder. However, you could argue that didn't help those same people who were in a lot of pain at the time.
Well, thank you. So our next question is, why do you think comorbidity does not receive more attention clinically and publicly?
Yeah, it's a great question. I think part of it has to do with the fractured nature. So like bipolar disorder is generally treated in psychiatry, sometimes primary care, it depends on access, but ideally like in psychiatry. Substance use disorders and sort of screening for substance use is either going to happen in primary care or maybe now in addiction medicine. There are just now starting to be addiction psychiatry programs, training programs, and clinics, but they're still not incredibly common. And I think it's one of those things where, as humans, sometimes if we don't have a great solution for something, it's hard to ask a question. And so, if our expertise is not in a certain area, sometimes it's maybe easy to do like a cursory screen, because if we find a yes, we might not know what to do with that. And I think that sometimes goes both sides, right? So like in primary care, addiction medicine, maybe less so addiction medicine, but I think in primary care, if somebody, screens for alcohol use disorder, is there a reflexive screen for bipolar disorder? I don't think there is in most practices, but I think there should be. So I think that's one of the big things. I think another thing is there's still this persistent idea that people kind of do things to themselves and kind of deserve what comes from them, and all of those sort of like residual stigma. And I do think in particular that plays in here because boy, both of these conditions, bipolar disorder and substance use disorders, are still highly, highly stigmatized each in of themselves. So, yeah.
Well, thank you. And so we have time for one more question today. And that question is regarding the quotes from the study of the individuals who live with bipolar disorder about their substance use, what information can be derived from that to help the issue at hand?
Yeah, I think one of the biggest things is even in that study and even in um, you know, how it was presented in the literature, I think there's a lot you can take out of those quotes to see that people are using substances because in the vast majority of situations there's an unmet need that is happening. And even when it might be framed as not necessarily that, I think if you really get at the heart of the matter and underneath what the quote is saying, a lot of in the vast majority, you're gonna find that there's an unmet need, and someone is doing what they can to fill that need. Um and I think it's important to empower us as a healthcare sort of sector, to find those unmet needs and provide solutions for people that are safer. Because I think, if someone is faced with an unmet need and there's solution A, which isn't perfect, but hey, it's okay. It's like a level C or nothing. Like a C is okay, right? But if like as a healthcare professional, we can, say like, yeah, this is a C, there's all these risks, right? But then I have like this other one that's like maybe a B plus or even an A minus, that person might have their needs met without reaching for things that either short term or long term can cause disease and death.
Excellent. Well, thank you so much, Dr. Nichols. And I want to thank everyone so much for attending today. And this webinar recording will be uploaded on ibpf.org. And we love to hear your feedback as well. So if you have anything to say or any questions, please email info@ibpf.org. And Dr. Nichols, do you have any closing comments?
I just want to thank everyone for joining today, and just remembering that we have a lot more opportunity to help our patients and help each other identify un and undermet needs and meet those needs.
Thank you so much and have a great day, everyone. Goodbye now.
Thank you.